All right, good afternoon, everyone. So welcome to Grand Rounds, Thursday, October 29th. We have a really great treat today, and it is my pleasure to introduce Dr. Nate Warner, who I'm sure many of you know is a new assistant professor in our infectious disease division, and also importantly serves a very important role as the associate clerkship director for the internal medicine program. Nate brings a lot of expertise. He graduated from BCU in 2013 from medical school and does his residency here, where he was a chief resident. Then undertook fellowship training at UNC, and we're just thrilled that we're able to recruit him back here to BCU. And I'm very excited because I think Nate is really going to revitalize our physical examination education curriculum and some bedside physical diagnosis, which is really near and dear to my heart, and I think a place we can excel as a Department of Medicine. So we're very excited to have you present, Nate, and thanks for coming to BCU. We're looking forward to your contributions for many years to come. So welcome, and I think this is going to be an exciting CPC.
Thank you, Dr. Syme. My name is Michael Sternberg. I'm one of the chief medical residents, and I'll be presenting our CPC case today, which focuses on a 43-year-old male with dyspnea on exertion. We have a 43-year-old white male with past medical history of obesity who presents with progressive dyspnea on exertion for 6 weeks. The patient explains that he's a runner and he has competed in marathons in the past. He used to run several miles 3 times per week, but 3 months ago, he noted worsening exercise tolerance and he stopped running. Since that time, he gained 15 pounds. For the last 6 weeks, he's been short of breath carrying his child and walking up steps. Over the last 2 weeks, he experienced paroxysmal nocturnal dyspnea and mild orthopnea. He describes intermittent episodes of diaphoresis and mild, sharp, substernal chest pain that only occurs with deep inspiration. On review of systems, he tells us about the dyspnea on exertion for 6 weeks, orthopnea and PND for 2 weeks, pleuritic substernal chest pain, and weight gain of 15 pounds. He denies lower extremity edema, typical chest pain, palpitations, lightheadedness, fevers, chills, and cough, as well as abdominal pain, bloating, diarrhea, constipation, melena, hematochezia, changes in urination, rashes, and any joint pain or swelling. His past medical history is only notable for obesity and past surgical history for a vasectomy approximately 1 year ago. His family history is notable for Hashimoto thyroiditis, both in his mother and his father. He has 2 young children with no medical problems, and he has no siblings. He has no allergies, and he takes no medications. His social history is notable for an 8-pack-year smoking history, but he quit smoking 10 years ago. He drinks 2 to 3 alcoholic beverages per week and denies past and present illicit drug use. He lives in Richmond with his wife and 2 young children. He's monogamous with his wife, and he works locally in real estate. He hasn't traveled outside of Virginia in the recent past and has no sick contacts. On physical exam, he's afebrile with a blood pressure of 110/80, heart rate of 120 beats per minute, breathing 21 times per minute, and saturating 92% on room air. His BMI was 35. He was alert, interactive, well-nourished, and in no acute distress. There was no scleral icterus, and his pupils were equal, round, and reactive to light. There was no conjunctival injection. His nares were patent without erythema or bleeding, and there were no lesions in the oropharynx. He was tachycardic with a regular rhythm, normal S1 and S2, with no murmurs, gallops, or rubs. His jugular venous pressure was elevated to 10 centimeters of water, and he had trace pitting lower extremity edema.
Give me a bad reputation.
He had bibasilar crackles, but adequate breath sounds heard in all lung fields bilaterally. There was no wheezing, rhonchi, no accessory muscle use, and no increased work of breathing. His abdomen was soft, obese, and non-tender, with active bowel sounds and no evidence of a fluid wave or organomegaly. There was no appreciable cervical, supraclavicular, inguinal, or axillary lymphadenopathy. There was no joint swelling, deformities, or muscle wasting. He had the trace pitting lower extremity edema with 2+ radial and dorsalis pedis pulses bilaterally. He was fully alert and oriented with full strength in his upper and lower extremities in all ranges of motion. Sensation was intact and his reflexes were 2+ throughout. There were no rashes nor bruising. His basic metabolic panel was only notable for a creatinine of 1.22 milligrams per deciliter without a previous baseline. Hepatic panel showed AST of 70 and an ALT of 111 with a normal alk phos and normal bilirubin. His white count was 8.3 with a normal differential, hemoglobin 14.6, and platelets 228. Coags were normal. Additional serum studies revealed an elevated brain natriuretic peptide of 540 picograms per milliliter and a troponin elevation of 3.5 nanograms per milliliter. CRP was mildly elevated at 0.8 milligrams per deciliter. He had a normal lactate and a normal TSH. His urinalysis did not show any evidence of proteinuria, glycosuria, red blood cells, or white blood cells, and his urine drug screen was negative. Other serologies included negative titers for Coxsackie virus. He was also negative for enterovirus, human herpes virus 6 and 8, parvovirus B19, Epstein-Barr virus, and Lyme disease. Additionally, he tested negative for HIV, both via antibody and PCR, as well as Hep C. His hepatitis B serologies showed immunity. His first ECG showed a sinus rhythm with a first-degree AV block, an atypical right bundle branch block, and diffuse ST segment depression, while his second EKG showed pleomorphic ventricular tachycardia with a rate of 120 beats per minute. Chest X-ray showed mild cardiomegaly with no airspace disease and no pulmonary edema. Transthoracic echocardiogram revealed a left ventricular ejection fraction of 30 to 35% with mild LV dilation and mild concentric hypertrophy. There was severe diastolic dysfunction noted, as well as inferior and mid to distal septal akinesis. The right ventricle was dilated with mild to moderate systolic dysfunction. The atria were normal in size and there was no significant valvular disease. The IVC was dilated, consistent with an elevated right atrial pressure. On cardiac catheterization, the coronary angiogram showed a 30% stenosis in the proximal LAD. The right heart catheterization revealed elevated right atrial pressure of 17 millimeters of mercury with normal pressures in the right ventricle, pulmonary artery, and pulmonary capillary wedge pressure. The cardiac index was depressed at 1.8 liters per minute per meter squared. His cardiac MRI confirmed severe left ventricular systolic dysfunction with an ejection fraction of 25%. There was severe regional left ventricular hypokinesis involving the septum and the anterior walls, as well as the inferior wall. The right ventricle was normal in size on the MRI with severe systolic dysfunction. There were multiple areas of delayed gadolinium enhancement, including a near circumferential involvement from the basal to the mid segments. These regions of delayed enhancement are patchy in distribution and subepicardial, which is not consistent with ischemia. There was high signal intensity on T2 weighted imaging in the regions affected by the delayed gadolinium enhancement, suggesting active inflammation or edema. The pericardium was normal without evidence of inflammation or effusion, and there was no mediastinal lymphadenopathy. And now I'd like to introduce Dr. Corey Tranquil to go over some of the cardiovascular studies.
Thanks, Michael. Appreciate the opportunity to walk through some of these images. So this is the first EKG that was referenced. I think there's a lot going on in this one, and so it's nice to take a sort of a standardized approach to a complicated EKG like this. So just to fill out a few things, first, the rate's around 78 or so, and the P waves are sort of embedded in the T waves. It's actually not super obvious from this EKG alone. This is an instance where the person who interpreted the EKG had to look at a couple of the other EKGs in which there were some PVCs that unmasked the relationship between the P waves that are hidden here, followed by a long PR interval, and then the QRS complex that followed suit. And so essentially this patient was found to have sinus rhythm with a first degree AV block with a prolonged PR interval. If you look at the axis, it's negative in AVF, it's kind of isoelectric to possibly slightly negative in lead 2 and positive in lead 1. And so you've got a borderline left axis deviation. And then if you look at these QRS complexes, they're markedly abnormal. Here we've got, in V2, you have a RS, R prime, S prime, and you can look at the morphology. There's lots of notching in the deflections themselves. And so this sort of suggests that since these are the leads that overlie the right ventricle, that there's something significantly affecting the conduction and involving the right ventricle specifically. This is followed by the second EKG that was referenced, where now you notice that the axis has completely shifted. Now it's positive in AVF, negative in lead 1. It just has a different morphology in general. It's faster. The rhythm is not quite certain yet. The QRS duration is long and abnormal. It doesn't necessarily follow a clear right or left bundle branch block morphology. And when you look at, when you try to deflection AVR, and that's sort of odd. AVR points upward towards the upper right extremity, and so it's the exact opposite direction that you would expect the depolarization of the ventricle to go. So anytime you see positive in AVR, that should grab your attention. And then if you look down here, you might be able to identify some P waves that are progressively sort of swallowed up by the QRS complex, suggesting that the ventricular depolarizations are happening faster than the atrial depolarizations. You have AV dissociation. And so this was interpreted as having pleomorphic ventricular tachycardia. Pleomorphic meaning that there's 2 predominant morphologies as opposed to polymorphic, where you might have greater than 3 morphologies. And then these are the cardiac MRI images. And so what you can see here are the CINE. These are before giving any contrast. We're looking at the contraction of both ventricles. And so you should see both wall motion and thickening of the myocardium during systole, which is impaired in several segments. And so if you put it over here, you can notice that all these segments with red symbols over them, not only do they not move very well, they're not thickening either. And you can't really identify any one coronary artery that would explain this. You can't say that if the LAD went down, that would explain all this. It's affecting multiple coronary territories. And then here are the delayed gadolinium enhancement. So we've given contrast, gadolinium-based contrast. We've waited about 10 minutes. If you have a healthy myocardium, it should wash out of the myocardium and appear black in these images. If you have something like a scar, disruption of the cellular integrity, then the gadolinium is going to stick around and show up as bright. And so here we have multiple territories affected by late gadolinium enhancement. And sure enough, they match up with the abnormal wall motion and thickening in the CINE images. Not only that, the coronary arteries are epicardial. So if one of them were to occlude, you'd expect the subendocardial surface to be the first thing that dies and the first thing that has late gadolinium enhancement. This is all subepicardial based late gadolinium enhancement, suggesting that the mechanism of injury was not a myocardial infarction. It was something non-ischemic in etiology. And then this is a T2 weighted image, and these are a little bit harder to look at, but what you can see is the areas that are normal by wall motion and late gadolinium enhancement down here have somewhat of a darker shade of gray than what is up here affected by delayed enhancement in these images and has abnormal wall motion. So whatever's affecting this, it has high T2 signal intensity, which tends to represent areas of active inflammation and edema. And so the overall interpretation was, as Dr. Sternberg said, severe biventricular systolic dysfunction, scar, non-ischemic etiology with active inflammation or edema. I'll turn it back over to you.
Thanks, Corey. Double.
All right. Thanks, Corey. So I'm Nate Warner. I'm excited to take this case on, and hopefully I'll be in the ballpark. So I'd like to take you through my clinical reasoning for this case. And so this is a 43-year-old gentleman and 3 months of symptoms, essentially. So he stopped running due to exercise intolerance, and then he got some overt dyspnea on exertion, and then developed kind of classic heart failure symptoms, and then had some pretty interesting episodes of diaphoresis and chest pain, which we don't really know the cause of just yet. And then he presented to the hospital, presumably due to progressive symptoms. And so kind of going through a diagnostic schema of chronic progressive dyspnea, in my mind, I think of heart problems, lung problems, and then some other miscellaneous items, including anemia, increased metabolic demand, chest wall abnormalities, neuromuscular issues, as well as even anxiety. And so going into speaking with the patient, as well as examining the patient, I'm going to be thinking about these things as I examine him. And so past medical history is notable for obesity, no medications, no allergies. Interestingly, a strong history of Hashimoto thyroiditis, which increases his risk of having an autoimmune, something autoimmune going on. And then also notably, no cardiovascular disease, no sudden cardiac death in the family. And then a little bit of alcohol, a little bit of smoking in the past, no drug use, 2 kids, so maybe he's at risk for a virus, no travel, no sick contacts, and he works in real estate. And then we went through the review of systems already. So I find that I can never remember everything that I want to ask all at once. And so I find for some of these kind of complicated, undifferentiated syndromes, I'm always needing to circle back to the bedside. And I think that's kind of a natural part of the diagnostic workup. It's not just one discrete interaction with the patient at the bedside. It's kind of a cycle of going to the bedside, coming back, thinking, and then coming back to the bedside. So a couple questions that I'd like to maybe ask is ask the patient what he thinks is going on. I think that can be a really helpful question. The other is, does he have a PCP? Because he only has a history of obesity, but now is that because he has never been to a doctor in 15 years and it hasn't been diagnosed? Or is that truly because he doesn't have any other medical problems? Any non-prescribed medications is really important in this case. And then family history, I think I'd probably like to revisit kind of maybe person by person just to make sure we're not missing anything. And so I'm a little concerned by his vitals. He's very tachycardic, he's tachypnic, and he's borderline hypoxic. He's fortunately in no acute distress, and his JVP is elevated at 10 centimeters of water. No conjunctival pallor, so presumably no severe anemia. His cardiac exam is notable for a regular tachycardia. He's not an AFib with RVR. No murmurs, rubs, or gallops. He has no increased work of breathing, but he does have bibasilar rales. His abdomen is benign, his neuro is non-focal, his skin is also non-focal, and he has trace pitting edema, and notably his extremities are warm, which is important when you're thinking about cardiogenic causes, because if they were cool, I'd be more concerned about impending shock. And then he has good pulses. And so just a little sidebar on jugular venous pressure. So when we estimate JVP, what we're really estimating is several things. So we're estimating CVP, which is an estimate of mean right atrial pressure. And then if we carry that, we can carry that all the way back to the left heart, as long as we keep in mind that there are a lot of things that can also elevate our JVP, in addition to right and left heart disease, including pulmonic stenosis, pulmonary hypertension, intrinsic lung disease, and even mitral stenosis. And so the question of how helpful is JVP has been studied. And so really we're asking ourselves, is it high or is it low? And so studies have shown that if clinicians estimate the CVP to be greater than 8 centimeters, then it greatly increases the probability that the catheter measurement, if we were to put a catheter in and measure CVP, would be also elevated with a likelihood ratio of 9.7. And then on the flip side, if we believe that it's normal, the likelihood ratio would be 0.1. And so that's actually really good. So if you have a likelihood ratio of almost 10, that's really increasing your post-test probability significantly. So if I had a 50% suspicion of heart failure and I did note elevated JVP, then that really pushes me up pretty high. Some studies have shown that it's maybe not that high, maybe closer to 4, but it's still a very helpful physical sign that we should work on. And so how do we do it? So first of all, setup is really important. So patients slouch in the bed, and that's your first problem. So get their neck in line with their torso, and then use the vein that you can see. So typically that's the right IJ, but sometimes it's the left IJ, and sometimes it's the EJ. And as long as it's not thrombosed, you can use it. And they do correlate fairly well together. And then place the patient, as you can see in this picture, at whatever angle brings the venous pulse into view along the neck. And so the next step is then identifying venous and arterial pulsations, or differentiating them, I should say. And so venous pulsations are biphasic. So you're really going to see that A wave and that V wave, whereas carotid pulsations are just monophasic and outward. There's respiratory variation. You should go up with expiration and down with inspiration. The venous waveforms have a very prominent inward movement, and they're more diffuse, and they typically obliterate with pressure. And so I have this video, hopefully it'll work, and it kind of goes through venous waveform identification, then quantitative assessment, and then a couple qualitative examples. It's my first time making a video. So as you'll see here, this is the venous pulse, which is more diffuse, it's collapsing, and it's different than this carotid pulsation, which is outward and monophasic. This is Dr. Fadden here with the venous pulsation. And let's say that we're not sure that that's a venous pulsation, we can elevate the bed and we can watch it disappear, and that confirms to us that that's a venous pulsation. And then this is a woman with markedly elevated JVP, and you can see the biphasic venous pulsation next to the carotid pulsation anteriorly. And so this is the Lewis method of quantifying JVP. So we have 1.5 centimeters plus 5, so approximately 6 centimeters of water. And then we didn't quantify this here, but as you can see, this woman is at 90 degrees, and so she has markedly elevated JVP. And this is just confirming the venous waveform. And so this sign, as you can see here, is more kind of a diffuse, prominent outward movement. It's monophasic. So this is actually a combined CV wave that you can see in severe tricuspid regurgitation. And this is a gentleman with severe emphysema. And as you can see, when he's inhaling, his venous pulse is rising, which is paradoxical. And so this would be an example of Kussmaul's sign due to decreased right ventricular compliance. And this is another example of the CV wave. So back to our case. So based on our history and our physical examination, I think we're solidly in the cardiac corner. And so if we kind of go down that route, what comes to my mind? So I'm thinking vascular, so coronary artery issues such as coronary disease. And this is kind of the pre-cardiac MRI. We're sort of working up from the beginning. Valvular processes hopefully is less likely since we didn't hear any murmurs. We don't see any evidence of endocarditis. Tachyarrhythmias can cause heart failure in and of themselves, a primary myocardial process, or even a pericardial process. So let's get some labs, chest x-ray and EKG. So I think we went through these, but essentially I think this kind of doesn't, these labs are not entirely surprising for this patient's presentation. I will point out for the future that the eosinophils are 0, and I think that's important. Thyroid is normal, and the BNP is elevated at 540, which is positive and not surprising. And then the troponin is 3.5, and that's important. And so I'm thinking to myself, perhaps this is an MI event, or perhaps this is demand ischemia in the setting of a heart failure exacerbation, or perhaps this is myocarditis. And so the chest x-ray is fairly unremarkable. Notably, no hilar adenopathy for the future, but also no pulmonary edema. So perhaps more of a right-sided process, or perhaps the CVP is not elevated enough to make overt pulmonary edema. And then we went through the fact that there's severe intrinsic conduction system disease in the EKGs and a pleomorphic ventricular tachycardia, as well as biventricular reduced EFs and focal wall motion abnormalities. So to pause and summarize, we have a 43-year-old previously healthy gentleman with a family history of autoimmune thyroiditis who presents with chronic progressive dyspnea on exertion associated with PND, orthopnea, and substernal pleuritic chest pain. Physical exam significant for mild to moderate volume overload. Ancillary studies showing troponin elevation, heavy conduction system disease, and decreased biventricular function. So tachycardia-induced cardiomyopathy, I do not think is the primary cause in this case. So typically, folks with very high heart rates are going to present with tachycardia-related symptoms, whereas lower heart rates in the 120s may present with heart failure symptoms. So I think perhaps the tachycardia could be making it worse, but I don't think this is the underlying cause in this gentleman's case. Constrictive pericarditis also is not likely in this case. He doesn't have risk factors for it. He doesn't have a Kussmaul sign or any Y descent, prominent Y descent on his JVP. And then the echo did not show any ventricular interdependence, which when the pericardial sac is tight, there's limited pressure. And so during inspiration, the tricuspid valve inflow speeds up, and then concurrently the mitral valve slows down, and then the opposite happens during expiration. So we're left with vascular and myocardial. And so if let's say that this patient came in with chest pain. We're not totally sure about that. But let's say that this is a 43-year-old gentleman who presents with acute onset chest pain in the setting of in the setting of chronic progressive heart failure symptoms, VTAC, troponin elevation. To me, I'm going to call Dr. Tranquil here and have him see the patient. Unfortunately, we have a catheterization, which shows non-obstructive coronary disease, and interestingly, elevated right-sided pressures with fairly normal left-sided pressures or wedge pressure. So perhaps the right side of the heart is faring worse than the left, or perhaps depending on where this patient is, maybe there's a balloon pump in place, not sure exactly. And also the cardiac index is down, which is a poor prognostic sign. So myocardial process. So I think at this point, I can fairly certainly say that this is a non-ischemic cardiomyopathy. And by that, we mean that we have a heart failure in the absence of pressure overload, such as hypertension, valvular disease, or ischemic causes. And so to me, we're in the realm of acquired and genetic. And my main question is, with this subacute non-ischemic cardiomyopathy with troponin elevation, is this myocarditis? And so our next step is the MRI, which we reviewed together. But in a nutshell, there's focal wall motion abnormalities not correlating with coronary anatomy. There is inflammation as evidenced by the T2 signal, and there's scarring or necrosis by the delayed gadolinium enhancement. And this is subepicardial and patchy, and kind of more in the proximal region and sparing the apical area. And then no mediastinal lymphadenopathy, which will be important later. So does this patient have myocarditis? I would say yes. And so there's several different kind of criteria for myocarditis. There's the classic Dallas criteria, which is a pathologic diagnosis. So we don't have any pathology at this point, but it's important to know that this exists. And there is some concern that it maybe has a low sensitivity when it comes to some cases of myocarditis. And so there is some rethinking about the utility of that criteria. There's a kind of a clinical criteria proposed by the ESC, which I think makes sense. And so this patient would qualify based on the dyspnea, the palpitations, the troponin elevation, cardiac findings, cardiac MR findings. And then there's a Lewis-Lake criteria, which basically means edema, hyperemia, and injury or scar. And so we have edema and injury or scar. And so I think at this point, from a myocardial perspective, we're looking at myocarditis and then also a mimicker of myocarditis, ARVC. And so we're starting to get into the realm of where I am a little bit shaky as far as my knowledge goes. So I sat down to review the literature, and what I kind of came to the conclusion of is that myocarditis seems to be a little bit like the ILD of pulmonary or pulmonology, and that if you add more and more terminology, it just gets more and more confusing and difficult for a novice to take a stab at. But nonetheless, there are lots of different classification schemes proposed. And so at this point, I would say that a 43-year-old without a viral prodrome and without any evidence of systemic autoimmune disease is presenting with a subacute, complicated biventricular myocarditis, as evidenced by impending cardiogenic shock, I think, and heavy conduction system disease and pleomorphic VTAC. And so I still don't have an extremely clear understanding of myocarditis, but I think that's because the science is not totally clear yet. But what I do know is that I think there's a majority of cases of myocarditis that are subclinical and we don't detect. And so those are likely from viruses. There are also a large proportion of detected cardiomyopathy or myocarditis cases, which are symptomatic enough to come to presentation, but have a good prognosis. And so because of those cases have good prognosis, we don't have a whole lot of studies about them or classification schemes for them. But then as you get into the more severe myocarditis, whether that's fulminant or whether that's due to kind of progressively worsening heart failure or progressively worsening ventricular conduction disease, you start to get to where you need to rule out specific causes. And as a general trend, these causes become less likely to be infectious and more likely to be autoimmune and inflammatory. And so this is where the aggressive workup is necessary because many of these cases are treatable and many of these patients need to be transplanted. So fulminant myocarditis is exactly what it sounds. So it's a fulminant presentation of myocarditis, and typically these patients come in within the first month of symptom onset, and they come in really, really sick. So cardiogenic shock sick, needing Impella and balloon pumps and sometimes ECMO, and they can have active myocarditis on exam. And so these patients have a class 1 indication for biopsy because these patients can have different pathologic phenotypes, including lymphocytic, eosinophilic, giant cell, and granulomatous. And so lymphocytic, actually has a good prognosis. So if you have lymphocytic, as long as you can keep them alive in the cardiac ICU and they get better, they should do pretty well. That's in contrast with these three here, particularly giant cell. And giant cell is an incredibly fulminant disease with a very poor prognosis and frequently requires transplant. And we'll get into that a little bit more in a second. And then eosinophilic and granulomatous also require immune suppression. So diagnosing them by biopsy is very important. And I would say that because of his symptom onset of greater than a month, he's really not, and he's also not yet in shock. So I would say that he's really not meeting these criteria for fulminant myocarditis, even though I'm very worried about his hemodynamic status. So I will say that I think he has a complicated subacute myocarditis. And the complicated piece comes from the fact that he has a decreased EF on presentation, he has VTAC, and he's hemodynamically unstable. And so the diagnoses that need to be investigated are here. And I would say that eosinophilic myocarditis, I do not think is going on. And so this is a group of diseases frequently caused by either hypersensitivity due to a drug or systemic autoimmune disease or Strauss or hypereosinophilic syndrome. And so we don't have any eosinophilia, we don't have any evidence of a drug, we don't have any evidence of autoimmune disease. So I would say I'm going to go ahead and rule that one out. And so let's talk about giant cell myocarditis. So we just spoke a little bit about it, but it's rare, but it's rapid onset, it's fulminant, and it's deadly. Typically, these patients come in within 2 weeks of symptom onset, but from what I read, there is a range, and so I kept it in the differential because of this range here, and because it's so deadly, and we don't want to miss it. The mean age is 42. The cause is idiopathic, though there is some association with autoimmune disease. Cardiogenic shock is the rule, and lots of ventricular arrhythmias are associated with it. Biopsy is the gold standard. Without immunosuppression, it's almost uniformly fatal. And even with transplant, the recurrence rate in transplant, I think, is about 10%. So very, very severe disease. From what I read, the cardiac MRI findings are somewhat nonspecific. It can involve both ventricles in a kind of full thickness distribution or patchy. And so then the primary differential diagnosis for this would be, in this case, I think would be the remainder of these diagnoses that we'll talk about. I also did read after I made this PowerPoint slide that pleomorphic VTAC can be associated with this disease. Acute lymphocytic myocarditis is most commonly associated with viruses. It can be associated with autoimmune disease less commonly. I think in this case, viruses are unlikely. And the most common ones here would be enterovirus, adenovirus, parvo, and HHV6. Other important viruses would be the hepatitides and HIV. Most of the time these viral diseases are not so severe. They're not so fulminant. They're not associated with this severe amount of conduction disease and subacute kind of progressive heart failure. And then again, we don't have any systemic evidence of a systemic autoimmune disease either. Going through the serologies and the labs, I think the HIV is very important. The hepatitis is very important. The Lyme is important for Lyme carditis, though I don't think that, I think that this is too severe a presentation for Lyme. The interpretation of Lyme antibodies is always a hot topic, but essentially there's an ELISA screen. If that's positive, it goes to a Western blot. And if you have over, I believe, about 3 weeks of symptoms, you only interpret the IgG. And so it would be, if it were positive, you'd have 5 or more out of 10 IgG bands, which would be qualifying as positive. In this case, it's not positive. The viral PCRs here, I don't think are that helpful. And the reason for that is that viruses clear from the blood typically within a week. And so most of the time, these patients, by the time they see us, have already cleared the virus from blood. And so the literature about viruses and cardiomyopathy is mostly from PCR of endomyocardial biopsy. And that's typically done more commonly in Europe rather than in the United States. How much time do I have? 7, 6, 7. Okay, so now we're at the last two. So cardiac sarcoidosis associated with systemic sarcoidosis. So our patient, though he's not had a complete workup, like chest CT and ocular exam and all that stuff, we don't have systemic evidence of sarcoid. So then that brings us to isolated cardiac sarcoidosis. And so I wasn't as familiar with this, but sarcoidosis can really cause a myocarditis and mimic a myocarditis. It can cause a lot of inflammation. And so the fact that the RV is involved, that there's a lot of arrhythmia and conduction system disease makes me suspicious for sarcoidosis. And so reviewing the diagnostic criteria for isolated sarcoidosis, you have to have no systemic extra cardiac sarcoidosis. We don't have a PET, and so it says that there cannot be any FDG PET uptake in any organ other than the heart, and you need to have a chest CT negative for lymphadenopathy. And then from a clinical, assuming that this is all negative, from a clinical perspective, you need to have a high-grade AV block, which we do, ventricular arrhythmia, which we do, no note of basal thinning of the ventricular septum. From what I read, the thinning is more commonly in the chronic phase of sarcoidosis, so maybe we are not there yet. We do have a reduced EF, and we do have delayed gadolinium enhancement. So from a diagnostic perspective, we may be looking good for isolated cardiac sarcoid. And then the MRI findings, I think are consistent with what we see on this MRI. So non-coronary distribution of the wall motion abnormalities, increased wall thickness. I'm not sure that we had that per se, but we do have increased T2 signal. And then also of note, the pleomorphic VT, there was a study which I forgot to cite, that compared idiopathic VT to patients with sarcoidosis, and pleomorphic VT, meaning more than one VT morphology, was present in 50% of the sarcoidosis patients and none of the idiopathic VT patients. So I don't know a whole lot about pleomorphic VT, but that was something I found. And so how many patients, basically how common is isolated cardiac sarcoid? And so this one study of 275 patients showed that 12% of them had isolated cardiac sarcoid by PET. This is likely an overestimation because there's a false positivity rate in patients who get catheter ablations, as well as an overlap from arrhythmogenic cardiomyopathy, which I'm going to discuss next. So a sarcoid mimicker, essentially. So ARVD is something that I've just learned a lot about in the last couple of days, but it is a genetic cardiomyopathy that occurs kind of fairly rarely. But basically, it affects the genetic defect is affecting the desmosome, which is essentially you can think of as the bolt that holds the cardiac myocytes together. So there's several different mutations, but it's common in young athletes, and it can present between adolescence and 40s. And the thought is that there's this genetic susceptibility because of the weak bolts in between the cells. And it's thought to be more common in athletes because exercise increases the strain in the RV disproportionately to the LV. And so you have increasing shear stress in the RV, stressing the myocyte junctions, cell injury, inflammation, apoptosis, and then scarring and fatty infiltration. And then this is a highly arrhythmogenic disorder. So these patients need to be identified and get ICDs. And so the first paper that described ARVD was in 1982, and it described this triangle of dysplasia where the dysplasia occurs. This is not actually correct anymore and has led to some misdiagnoses. Notably, the apex is not involved early. It's not involved until it's progressed all the way down the RV. And so the correct triangle per se is involving the inferior and anterior RV, as well as extending kind of like behind the heart to the posterolateral LV. And so I'm not going to get into the diagnostic criteria, but essentially our patient does not meet diagnostic criteria for ARVD. But looking at the genetic mutations of ARVD, the most common is PKP2 or plakophilin 2. And excuse me. And then this DSP2 or desmoplakin is seen about 10% of the time. And basically what the researchers in ARVD found is that exercise, the sympathetic nervous system contributes to worsening disease. But they've also found that there's also an inflammatory component to this disease. And in addition, some patients were increasingly recognized to have ARVD when they were initially diagnosed with myocarditis. So those patients who eventually became diagnosed with ARVD ended up having this desmoplakin mutation. And so it's kind of an inflammatory myocarditis. And also notably, there is LV involvement over RV involvement in this desmoplakin mutation. And so this was published earlier this year, and it was a comparison between the desmoplakin mutation as compared to the standard plakophilin 2. And so notably, the LV was more commonly involved in the DSP group, whereas the right ventricle was more involved in the plakophilin group. Basically, there's delayed gadolinium enhancement and subepicardial distribution in a good number of these patients with DSP. And then most notably, in 4 cases with positive PET scans, acute myocardial injury associated with inflammation, they were initially misdiagnosed as cardiac sarcoid or myocarditis, and then ultimately diagnosed with this cardiomyopathy. So does this patient have an inflammatory DSP cardiomyopathy masquerading as myocarditis? I'm not sure. What I will say, which is I'm just using context clues here, is that Dr. Trankel, who just interpreted our MRI, 2 months ago published 3 cases of inflammatory desmoplakin cardiomyopathy masquerading as myocarditis, but the cases don't match our case. So is this isolated cardiac sarcoid or is this DSP inflammatory cardiomyopathy? I think cardiac sarcoid is, I think, more common than ARVD. I think that this patient likely would meet diagnostic criteria with an FDG PET. I think the pleomorphic VT is supportive, and that, as is the heavy conduction system disease and subacute time course. The con is that there's no extracardiac signs of sarcoid. And then this DSP, I mean, this is sort of a mimicker, so it's hard to rule it out right off the bat. I will use my context clues here. And then the cons is that this is a rare variant of a rare disease, and the patient has no family history, and so would have to be a proband, so the first mutation. And so I would say, based on that, that I'm going to go with isolated cardiac sarcoidosis as my final diagnosis. And I'm going to get an endomyocardial biopsy for which the patient has a class 1 indication. And so I think, why do we get the biopsy rather than the PET or genetic testing? I think we need to catch what we can treat and what is imminently life-threatening. And so that includes sarcoid. It also includes giant cell. And then if the biopsy is negative, then I would go for an FDG PET as well as a DSP genetic testing concurrently. And with that, hope I'm in the ballpark, and thanks so much. I get by with a little help from my friends.
Hey. Hi everyone, I'm Nicole Johnson and I'm a 3rd-year pathology resident, and I'll be going over the surgical pathology findings in this case. Just to get started, just want to spend a minute just showing normal for the heart. So this is showing the anterior surface of the heart. Vasculature, oh, I gotta share. New share. Thank you. Okay, so we'll look at the normal heart. So this is showing the anterior surface of the heart, normal posterior surface of the heart. And then a normal average weight for a female is 250 to 320 grams and 300 to 360 in a male. Normal right ventricular thickness is 0.3 to 0.5 centimeters. Left ventricle is 1.3 to 1.5 centimeters. The heart is a modified artery and thus has 3 layers. The innermost layer is the endocardium, made up of the endothelium and the subendocardial layer. The myocardium is the cardiac muscle made up of the cardiac myocytes. And then the epicardium is where the epicardial fat and the vasa vasorum lie, and then it's lined externally by mesothelium. This is showing a normal heart histology. You can see the heart fibers, and this is a vessel surrounded by some adipose tissue. And then just a little bit closer view showing the syncytial nature of cardiac muscle. So an endomyocardial biopsy was performed on this patient. 2 specimens were sent. They were both designated endomyocardial biopsy. Specimen 1 was 6 small fragments of white tan tissue, and specimen 2 was 2 fragments of white tan tissue. And both specimens were entirely submitted for evaluation. This is from specimen number 1. You recall a few slides ago. This does not look anything like the normal heart that we just looked at. You can see that most of this background is fibrosis and like this diffuse pink. There's an inflammatory infiltrate, all these small purple blue dots. These are large giant cells in here. And then you can kind of see it's little bit hard, but there are a few eosinophils. You can tell because they've got this bright kind of magenta cytoplasm. There are a few scattered throughout. There's one here and one here. And then there's this crush artifact over here. This is from specimen number 2. There are a few normal heart fibers in here, but it's predominantly some fibrosis, and there's an inflammatory infiltrate right here. So this was called active myocarditis, and just to recap what we just looked at, sections showed small myocardial fragments with a significant lymphocytic infiltrate and crush artifact. There were scattered eosinophils along with giant cells. No well-formed granulomas were seen, and patchy areas of myocyte necrosis could not be excluded. The differential given was lymphocytic myocarditis versus giant cell myocarditis versus sarcoidosis. Stains were performed in negative for fungal and acid-fast organisms, and viral PCR was sent out on specimen number 1 and came back negative for adenovirus, CMV, EBV, enterovirus, and parvo. So after the endomyocardial biopsy, he was treated for acute myocarditis with multiple immunosuppressive medications. He developed continuous pleomorphic ventricular tachycardia that was refractory to amiodarone, lidocaine, and stellate ganglion block. He subsequently developed cardiogenic shock and was cannulated peripherally for VA ECMO. He was listed status 1 for heart transplant and underwent successful orthotopic heart transplantation on day 12 of hospitalization. The explanted heart was subsequently sent up for pathology evaluation. This is just diagramming out how hearts are typically grossly dissected. The most common one is this one on the left, showing that the heart has been sectioned breadloaf from apex to base, with the last slice being just before the base of the heart, right before we get to the valves. And then the valves are opened for evaluation. The one on the right is opening the heart by flow, and what that means is we're following the course of the blood flow through the heart and opening it, such as going through the tricuspid valve down to the apex and then up and out through the pulmonic valve. And then on the opposite side of the heart, coming down through the mitral valve and then out through the aortic valve, making 2 V-shaped pieces of heart. And this is typically done in pediatric hearts, or if there's another situation in which the structure of the heart needs to be left intact. And this is showing a heart that's been suctioned from apex to base. It's this brown color because it's a fixation artifact. And then this is more of a fresh heart with the red-brown heart muscle, and showing that the base of the heart was open at the valve. So you can see the large tricuspid valve, pulmonic, mitral, and the aortic valve. So the explanted heart was 475 grams, which when I inputted his age, sex, height, and weight into the Lund forensic heart weight calculator, it estimated his heart size would be, normal heart size would be 480 grams, so that's within normal. The right coronary and left anterior descending arteries were grossly found to have about 50% occlusion, while the left main, left circumflex, and posterior descending had minimal atherosclerosis. The wall thicknesses and the valve sizes were within normal range, and representative sections were taken of the coronary arteries, atria, septum, ventricles, and the valves. So this is over here, you can see there's fat. This is a normal appearing heart, and then we have all of this, which is fibrotic, and there are scattered giant multinucleated giant cells throughout, as well as this lymphocytic infiltrate. The sections taken from the septum, left ventricle, and right ventricle all have similar findings. This is an area of myocyte necrosis, as can be compared to the more normal cardiac myocytes here on the right. Again, this is just showing the multinucleated giant cells, a lymphocytic infiltrate. Here you can actually see where the lymphocytic infiltrate is actually approaching the cardiac myocytes, and there are necrotic fibers here on the right. And then you can actually see the giant cell approaching the myocytes. So to recap, it was called myocarditis with predominant lymphocytic infiltrate, cardiac myocyte necrosis, diffuse fibrosis with prominent giant cells, though no granulomas or eosinophils were identified, and there's focal fibrin deposition. And then other findings were cardiac myocyte hypertrophy, the grossly noted calcific atherosclerosis, and myxoid degeneration of the heart valves, giving us a final diagnosis of giant cell myocarditis.
Thank you, Dr. Johnson. So this was a fascinating case, and I just wanted to point out a few facts about giant cell myocarditis. As Dr. Warner described in his presentation, the average age of diagnosis is 42 to 43 years. The majority of patients are white. This typically presents with symptoms of congestive heart failure, and sustained refractory ventricular tachycardia occurs in about 50% of patients. This was a particularly hard case because it can be indistinguishable from other forms of myocarditis and cardiac sarcoidosis without the endomyocardial biopsy. And it's often treated with immunosuppressive medications, but ultimately, without treatment, the rate of death or cardiac transplant is almost 90%. So I want to thank everyone for joining us for CPC today, and special thanks to Dr. Warner and Dr. Johnson and Dr. Trenkle.